Hello, friends. Today I have come up with a recent topic from urogynecology. In the question paper, there will be definitely a question from urogynecology. All are familiar with the different problems in urogynecology, that is SUI and overactive bladder. Overactive bladder is less discussed, so I thought I should talk about that. And today's topic is dedicated to this particular one. What is overactive bladder? Of course, the name suggests the bladder is very active. It's a chronic condition that has tremendous influence on quality of life in women and men. I'm underlining the word men. Overactive bladder is not restricted to women. It is also seen in men. But you must know that SUI is not common. In fact, it is almost not there in men because of the long deviated urethra. Whereas in women, there's a short and straight urethra. And when the posterior angle of the urethra is lost, there will be stress urinary incontinence. So that's why SUI is mostly the problem of women, whereas OAB is problem of women as well as men. The incidence in Asia is around 53%. It's a huge number. It's a very big number, right? So by definition, according to the International Continence Society, condition with urinary urgency. So I have highlighted the word urgency. So there is always urgency to urinate. So the person feels like urinating often. Usually accompanied by frequency. Urgency always accompanied by frequency. And what is to be noted is nocturia. So in the night, they feel like getting up and passing urine. Whereas SUI patient, usually whenever they are active, when there is intra-abdominal pressure is increased due to any reason, they will find that. Whereas OAB, even when they are sleeping peacefully, they will feel the urgency. They feel like getting up and passing urine. That is the hallmark. With or without urgency incontinence. See, this is very, very important. There can be incontinence due to OAB, but there need not be incontinency due to OAB. Whereas in SUI, there is always a small quantity of leak. There is incontinence, stress urinary incontinence. So that's why overactive bladder incontinence, it is not called overactive bladder incontinence. It is simply called overactive bladder because the incontinence may be there, maybe not. Because usually the patient here can sort of try to control consciously, but whereas in SUI is an unconscious dribbling of urine, a short, small quantity, all right, but it is sort of, they are unable to hold it. Here, sometimes they can hold it, but sometimes they cannot. But the most important sentence comes here: in the absence of UTI, SUI, or other obvious pathology. Now, why is this important? Because urgency, frequency are common symptoms of UTI. So, in order to diagnose or in order to blame the bladder alone, Detrusar alone, you have to rule out UTI. Also, to rule out the anatomical problem, that is the posterior angle I was talking about, you have to rule out SUI in order to squarely blame the bladder and call it overactive bladder. I hope I'm very clear. Things are very, very nicely mentioned in this particular definition. That's the beauty of definition. Earlier, I used to wonder why we should know the definition. Definition gives the whole gist of the topic. It sets the tone of the topic. So you now know what is OAB very clearly. This actually explains everything. So I'm highlighting again: in the absence of UTI, SUI, or other obvious pathology. Nocturia I'm underlining. Now let us look at the pathophysiology briefly. All of you know that the bladder is innervated heavily, sympathetic by L1, L2, L3, parasympathetic by S2, S3, S4, and These are autonomic nervous system, whereas there is also somatic nerves, again from S2, S3, and S4. And of course, that is from the pudendal nerve as far as the external sphincter is concerned. Whereas for the internal sphincter, there is hypogastric nerve that is also important for us. And as you can see, the receptors, the cholinergic and adrenergic receptors, M is equal to muscarinic receptors, N is equal to nicotinic receptors. As you can see, the detrusor muscle has got mostly the M2 and beta, whereas the mucosa and submucosa will have M2 and M3 as well. So bladder neck will be having alpha, urethra also is having alpha, and pelvic floor, of course, is nicotinic. So this is very important to understand because the treatment involves the drug therapy, and the drugs are directed towards these receptors only. So that is why I am putting this slide for the pathophysiology. And it is better you draw a diagram in the exam so that it will be easily understood. Again, a case of overactive bladder may not be kept in the practicals, but definitely it is a theory question. So you must understand before we go further, what is the different phases. One is the bladder filling phase. It's an intravesical pressure that should be lower than the intraurethral pressure. And only then the bladder will accept the urine that is coming from the kidneys. So intravesical pressure should be lower than the intraurethral pressure. But opposite happens when you want to empty the bladder. This is very simple physics and it's nothing great there. There should be decrease in urethral resistance and contraction of the detrusor muscle. Very, very simple, no brainer almost, right? So uterine or rather, sorry, bladder contraction. In the normal filling phase, what happens is there is parasympathetic inhibition and sympathetic stimulation, which reduces the detrusor tone. So there is parasympathetic inhibition and sympathetic stimulation. Whereas in the normal emptying phase, there is sympathetic inhibition and parasympathetic stimulation. So this increases the detrusor tone, right? So if you want to reduce the detrusor tone, you have to give something against the parasympathetic stimulation, isn't it? So this is another important pathophysiology that we need to understand while treating the patients. Parasympathetic stimulation. So anything against this will help the patient. So normal storage is dependent on, because see, it's not only filling and emptying. There is a period of storage when the patient has to keep the urine for some time. So this is due to a spinal reflex mechanism that activates sympathetic and somatic pathways to the urethral outlet. So urethra should be closed firmly. So then only the urine can be stored in the bladder. Tonic inhibitory system in the brain that suppress the parasympathetic excitatory outflow to the bladder. So this is very, very important. There are several theories why there should be overactive bladder. When we don't know the exact cause, there will be a lot of theories. The first theory is the neurogenic theory. We have gone in detail about the sympathetic, parasympathetic, and all that. Let's see what is this neurogenic theory says. There is reduction in inhibitory impulses and increase in afferent impulses from the bladder trigger voiding reflex. So it's purely the nerves that are confused. That's why they will always send a signal that now it's a time to pass urine, and they'll be getting impulses to contract the bladder. Whereas the myogenic theory is that the bladder muscle doesn't care for the upper story, that is the brain. It will take autonomy. It will act as an autocrat. And here, detrusor muscle becomes more sensitive to cholinergic stimulation, leading to increased spontaneous activity. So there is some stimulation, cholinergic stimulation, but the detrusor muscle decides itself. It was sending the signals, because if you involve the upper story, that is the central nervous system, it will tell you when to pass urine and when not to pass urine. But here, the detrusor takes control and it will take law into its hand and it will contract. Cholinergic stimulation. So we have to give anticholinergics. The autonomous bladder theory, that means exacerbation of phasic activity is gathered by muscarinic stimulation. So it is another sort of autonomic bladder. It will decide on its own, like autonomous status we have in many places. The afferent signaling theory, that means spontaneous bladder contractions during filling result in increased afferent output, hence awareness of bladder filling. See, normally we don't even know that the bladder is getting filled up. But the moment you come to know about it, or the bladder comes to know about it, it starts sending signals, and that will create a whole lot of confusion, and the bladder will start contracting. So there are different theories. We need to mention all the theories, but we don't know exactly what theory. But there are some points that we can see: muscarinic stimulation, cholinergic stimulation. So all these things will give us a clue towards the treatment. So how to diagnose? So diagnosis is already written in the definition. If you remember clearly, there is urgency and there is frequency, there is nocturia, but there is no urination on stress, and there is no urinary tract infection. So that's the definition. So it's the same thing what we are going to adopt here, but we have to know the risk factors, or who are the people who are likely to have this. Then the diagnosis becomes easier and simpler. You have to also take a detailed history, as I mentioned, what is mentioned in the definition. And of course, you have to do the examination. Any urinary complaint, you have to do a thorough examination. May not be the high level, but simple examination to basically to rule out any loss of angle or any prolapse and things like that. Investigations, again, simple investigation is good enough, basically to rule out infection rather than whole urodynamic studies. So let us see what are the risk factors. Older the age, of course, all the nerves, autonomic nervous system, central nervous system are mixed up. So older the age, overactive bladder is more common. Maybe very young age also, when we are toddlers, there is no control. But again, we go back to the same stage when we become old. Obesity, of course, here there is a whole lot of reasons for mix-up of situations. Obesity is another risk factor. Chronic constipation. Again, the constipation itself has got neurogenic theory. Maybe OAB is an extension of that, or mix-up of that, collateral damage. Vaginal deliveries. Yes, there can be injuries to the nerves and then mix-up due to vaginal deliveries. We again see vaginal delivery as a cause of a whole lot of urological issues in ladies. So as far as the history is concerned, we have to look at the symptoms carefully. If there is a problem with the storage, the patient will complain of frequency, urgency, nocturia, and incontinence. So means whenever the urine comes, he feels like passing urine. So there will be frequency, urgency, nocturia, and incontinence. If the problems are there, like hesitancy, straining, poor intermittent flow, again, it's a storage problem. Post-micturition symptoms. The patient has passed urine, but she still feels that I have not passed urine enough. That means sensation of incomplete emptying or post-micturition dribble, because the bladder is acting all the time. Other symptoms like nocturnal enuresis or dysuria. Of course, dysuria will help us in ruling out some sort of infection present in the urinary tract. Nocturia is important. So this is another small wording diary. So you can give it to the patient. Patient can fill up leisurely. If the patient cannot remember, sometimes they don't remember things. So you can give that to them, and then you can record that and review it later. Lifestyle is very, very important in every disease. Here also, we have to ask in detail when she takes the fluid, what type of fluid she takes. Caffeine intake, we all know, caffeine is a very good diuretic. And what time she takes, whether she takes late in the evening, night, just before sleeping, because that may be the cause of nocturia, or whether she's diabetic, whether she's taking alcohol, all of them. So again, if the history suggests that there is some neurological disease or spinal cord injury, you clearly know that that's a cause of OAB. Gynecologically, as I said, prolapse we have to ask and rule out pelvic surgeries and pelvic radiation, which can mix up the nerves or nerve injuries. Obstetrics, intrapartum or periurethral injuries, we should ask. And psychiatry, depression, anxiety, dementia. In dementia, people forget that they are past urine. They keep going to the toilet all the time, and it may not be necessarily OAB. So the history is not only to rule in, but it was also to rule out OABs. So we have to take a very detailed history. In fact, in every single spear, a lot of patience is required to ask the history. It said that history, you can make 90% of the diagnosis by history alone. So especially in this particular case, because you will soon realize that there's nothing much you can do in the investigation for these patients. Medication, diuretics, patient for all you know, maybe taking diuretics or maybe antihypertensives, neuroleptics, beta blockers. So all of these will give rise to overactive bladder type of symptoms. So what do you do in the examination? It should be focused organs involved in the urinary continence only, maybe bladder, bladder neck, and vagina, prolapse, and that around that. Abdomen, of course, you look for scars, masses, hernias, which may be pressing on the bladder, or hernias maybe again in the vicinity of the bladder. Vaginal, look for cystocele, rectocele, and rule out SUI by the famous test, whichever test you believe in. And then rectal, sphincter tone and fecal impaction should be ruled out, because I said there will be a close connection with the bladder and rectal continence or incontinence, whatever you say. Neurological, screen for Parkinson's and sacral nerve injury. Investigations. As I said, there's nothing much need to be done in a case of OAB. The history itself would have given you the diagnosis, but then you have to rule out certain things. Remember, you have to rule out especially the urinary tract infections. So investigation is very, very important. Urine analysis is the number one, that is to rule out the pus cells, hematuria, and glycosuria. Glycosuria is suggestive of diabetes. That may be the reason of polyuria syndrome. Culture, yes, very important. We know that there can be asymptomatic bacteriuria. That could be the cause of the frequency. So you have to do culture, and of course, not culture, but sensitivity test, so that you can treat that. And after treating also, if the symptoms persist, then you can say it was a mixed case of OAB and urinary tract infection. Now that you have completely ruled out UTI, it is a case of OAB, and you have to now give more drugs towards OAB. Post-void residual urine, of course, this is to be taken, especially patients who always feel like passing urine. It indicates poor voiding efficiency. Urodynamics and cystoscopy, as I've written here, not the initial treatment. In fact, it may not be required at all. It is used only in refractory cases where you have tried everything for the other things, and then still the person is having a problem. Then you can do some urodynamic and cystoscopy just to rule out if there's anything else that you have missed. Cytology, again, not routinely recommended because the cancers hardly give rise to this kind of situation. What are the differential diagnoses of OAB? Nocturnal polyuria, usually they will have large volumes, more than just 2 times. So polyuria patients, they will always have large volumes, and whereas in the overactive bladder, there will be small volume. Why? Because the bladder is not giving time for storage at all. So whatever little urine is there, it wants to pass. So every time the quantity is small. Whereas in nocturnal polyuria, it's always the large volume, and it is more than 2 times polyuria. Polydipsia, again, you have to rule out diabetes. Whenever a patient has got polyuria, polydipsia, for all you know, you may be dealing with a case of diabetes. Interstitial cystitis, dyspareunia, and pain on bladder filling are the leading symptoms. That's how we can differentiate interstitial cystitis from OAB. Stress urinary incontinence, of course, this is the closest cousin of OAB, and many people, many even famous gynecologists get confused with this. Stress urinary incontinence, we should be very clear that it is a situation where patient cannot stop urinating. Whereas in OAB, they feel like passing urine, but they can wait till they see the, let's say, the bathroom or the restroom. Whereas the stress urinary incontinence, without their knowledge, they would have leaked a little bit on stress only. Stress is not psychological stress, it is just physical stress, whichever increases their intra-abdominal pressure, coughing, sneezing, laughing, jumping, dancing, things like that. So on physical activity and small quantity, no urgency. That's what you have to see. They don't have urgency. They don't want to pass urine actually, but the urine gets passed without their knowledge. There's no frequency. They can hold the urine for a good number of time, a good amount of time, but unless still they have a stress in terms of coughing, sneezing. There's no nocturia. If they are not coughing, not sneezing, not laughing, just peacefully sleeping, there's no incontinence. Nocturnal incontinence, again, is not seen in these patients. So they can reach the toilet in time, whereas sometimes the OAB patients, even though they would like to wait till they go to the toilet, but they cannot control. But these people can go to the toilet. And I'm underlining nocturia, can reach the toilet in time. So having understood clearly the issues regarding OAB, let's now look at the management. I've already given you large hints about the management right in the beginning. So the management is divided into non-pharmacological, which includes basically education. You have to not only train the bladder, you have to train the person, you have to educate the person. So look here, this is the problem. So you should be, probably they should pass urine more frequently on their own. In fact, we used to have a very famous urologist. He used to say the simple treatment for any urological problem is ask the patient to pass urine frequently. But then the patients would say that exactly is the problem. We don't want to pass urine very frequently because, especially in a country like ours, the restrooms are not there everywhere. And ladies cannot go anywhere and everywhere to pass urine. So that is, again, a big controversy. Behavioral therapy is very, very important. And then bladder training. I told you bladder training, behavioral therapy, education, they are all part of the same spectrum. Lifestyle changes. This is something which is possible, like you avoid drinking water in large quantities and avoid drinking coffee in large quantities again, and avoid drinking late in the evenings and night. Avoid alcohol, at least in the night. That doesn't mean that you can take it in the daytime. So basically avoid alcohol all the time. Pelvic floor exercises. Yes, of course, this will strengthen the muscles and other things. But again, the problem is not that of pelvic floor as such in an overactive bladder. The problem is with the bladder itself. But anyway, as a general exercise and general control, probably this is going to help. So there's very little that we can offer in actually non-pharmacological bag as far as OAB is concerned. The main treatment of OAB is going to be pharmacological, unlike in SUI, which is surgical, basically. See, one basic rule in general medicine, as medicine on the whole, is that if there's an anatomical problem, it has to be corrected by surgery. For example, a prolapse, no amount of drug can help it. A fibroid, big fibroid, no amount. Of course, now there are drugs, but they are all very temporary. Ultimately, you have to resort to the surgery. Whereas if the problem is not anatomical, it is pathophysiological, then surgery is not required for that. Drugs are required for that. Similarly, here, as we have understood right from the beginning, OAB is not the problem of anatomy, it's a problem of pathophysiology. So pharmacological agents are going to help a lot in that. So we have seen in the first two slides, if you recall, it's a overactivity of the cholinergic agents or muscarinic receptors. So antimuscarinics, which is nothing but anticholinergics, are used basically. And the new drug is mirabegron. It's not new really. It's been there for now quite some time. It is beta-3 agonist. Finally, a small role for surgery in OAB also, especially if the drugs have not helped the patient or you have exhausted everything and patients don't feel like taking drugs on a long-term basis. So whatever small help we can do with surgery is that minimally invasive surgeries, that is botulinum toxin A. So this is not actually surgery if you look at it, just because we are going to use some cystoscope to inject this botulinum toxin inside. Finally, it's a form of medicine only, but delivered through surgical means. So this will basically increase the bladder capacity. That's why it is given. PTNS is another small surgery I'm going to talk a little later. The invasive ones are augmentation cystoplasty, because if botulinum is not doing its job, then you may have to do a cystoplasty to increase the capacity of the bladder. But again, after some time, it will go back to its overactivity. Urinary diversion is the final resort, wherein you bypass the bladder, which is the villain, and you divert the urine through the ureters, directly implanting it into the intestines, something what you do in cases of cancers in the cervix, last stages. So behavioral therapy basically includes fluid management. I've already told you that. Ask her to take a fluid according to the thirst, because nowadays we see so much everywhere in the internet, WhatsApp University, that you have to drink minimum 8 bottles of or 8 glasses of water and so many bottles of water, this and that. I was having a good discussion with a physician, and he told me that water should be drunk as per the thirst, not really. But then again, you get confused after the age of 60. You don't feel thirsty as much as you actually require water. So then how to balance? So there are a whole lot of discussions, but here a person with overactive bladder who is probably elderly, fluid management is very, very important. Timed voiding. Again, the simple advice given by the urologist to keep voiding urine so that you don't allow the bladder to overact and trouble you. Avoid bladder irritants like caffeine, alcohol, acidic and spicy food. These are good things for many people, many of us, and it is unfair to ask to avoid these things maybe. Avoid diuretics and antihypertensives. Of course, if you are hypertensive, you have to take them. But what is meant here is that you can have other drugs. Now, there are very drug ARBs, ACE inhibitors, instead of using diuretic as an antihypertensive. But sometimes, some of the drugs will cause edema. Amlodipine will cause edema. So they get scared. And so the physicians will prescribe an antidiuretic. So you have to inform the physician that you have the problem of OAB, so to avoid and diuretics as an antihypertensive therapy. Treat constipation. Of course, this is a challenge, both from the point of constipation as well as from the point of OAB. Pharmacological therapy. Finally, I come to the D therapy, that is pharmacological therapy. Bind and block muscarinic receptors. Simple. So you have to just take care of the muscarinic receptors, which are the ones who unnecessarily trigger and inform the bladder to contract. So if you block them or bind them, that is the best. So reduce the detrusor overactivity and stabilize it. So they are all part and parcel of the same thing. Improve bladder capacity. As I told you earlier, you can either drill the bladder or you can actually give some botulinum toxins and things like that. Improve the symptoms. The pharmacological therapy will improve the symptoms as well. They do other jobs like they bind, they reduce the detrusor overactivity, and they improve the bladder capacity. So what are these antimuscarinic agents? Time immemorial. The ones which have been there from my PG days is oxybutynin. That's a popular one. The dosage is 2.5 to 5 milligrams twice a day or thrice a day. The caution is in renal and hepatic diseases. Which drug is not caution? As far as renal and hepatic diseases, all drugs go through liver and kidneys. So this caution is for all the drugs. Side effects, of course, their job is to decrease the fluid everywhere. Maybe that's why there will be dry mouth, and because of decreased fluid, constipation and cognitive function also, because of maybe it is related to dehydration as well. The other ones are tolterodine, 2 to 4 milligrams per day, trospium, that is 20 milligrams per day, or solifenacin, 5 to 10 milligrams per day, terifenol, that is 7.5 to 15 milligrams per day. Again, the caution is same. the renal and the liver diseases in the patient. Derifenacin, that is the drug. And side effects, again, dry mouth, constipation, they are all same. Now I come to non-antimuscarinics, that is the latest one, mirabegron. So beta 3 adrenergic receptor agonist. So this is a wonderful drug. I have used it in many patients and it is really, really helpful. And it has got lesser side effects compared to oxybutynin. Here, the dosage is, there it was 2.5 to 5 milligrams. So just multiply by, let's say 10. So you get 25 to 50 milligrams, again, same BID to TID. Remember, oxybutynin 2.5 to 5, here it is 25 to 50. Caution, same. And side effects, tachycardia. So because these are beta adrenergic receptor agonists, there will be some tachycardia, hypertension, and constipation. Constipation is common. But tachycardia and hypertension will settle down once the patient is used to this kind of drugs. Usually we give it in the night, so there should not be any problem. The other ones, as I said, it is like a semi-medical or semi-surgical or surgico-medical, I should say. So you can inject botulinum toxin A through a cystoscope, 100 to 200 ml, 200 units intravesically. Caution is in renal and hepatic disease. Side effects, urinary retention and hematuria, because the bladder may totally relax and it will go to another extreme of urinary retention rather than urinary urgency and frequency and nocturia. It can go for hematuria if you have injected into the vessel areas. Tricyclic antidepressant, because overactive bladder is also some sort of a psychological problem. So you can give imipramine 10 mg BD. They themselves will dry up the fluids. Amytryptyline does the same thing, 10 to 20 mg. Tremor, arrhythmia, and nausea. These are some of the side effects of tricyclic antidepressants. So whenever there are two drugs, it is a famous time pass to pitch one against another. What is oxybutynin versus mirabegron? So mirabegron is efficacious in both naive patients and those who discontinued primary antimuscarinic therapy. What do you mean by naive patients? Naive patient means first time you are using oxybutynin. It's not that first time you are using mirabegron. It's not that you have used oxybutynin and then switched over to mira. These are called naive patient, or those who discontinued oxybutynin. Both of them are benefited by mirabegron. I'll repeat, those who took it for the first time or those who took it because oxybutynin was not working, in both of them it is efficacious. Its efficacy is superior when prescribed as a first-line therapy. So if you didn't use oxybutynin earlier and you straight away went for mirabegron, its efficacy is superior. So in other words, this drug is better as a first-line treatment. In refractory cases, failing two anticholinergics over 4 months period. That means you have already used both oxybutynin as well as mirabegron. These are called refractory cases. These are the ones who are requiring surgical treatment. What are the options? As I said, intravesical botulinum toxin type A, that can be done, or posterior tibial nerve stimulation. You saw this acronym PTNS. I told you I will tell you later about it. Actually, because I didn't remember the expansion of the acronym. So now but I was sure that it will be there in the next slide. So posterior tibial nerve stimulation is supposed to help. Sacral neuromodulation, whatever it means to you, I have not really tried to understand this. Maybe urogynecologist will be able to tell you that. Augmentation cystoplasty, as I told you, increase the capacity of the bladder by making flap surgeries. This is not that easy surgery. And then finally, urinary diversion, as I said, bypass the bladder and implant the ureters into the intestine so that the rectal sphincters will take care of the urine. But again, there also, once the rectum is full, the patient will patient will be confused whether to pass urine or whether to pass motion, or maybe both. I don't know. So I come to the end of the talk, and in fact, I happened to attend this retreat where I was a member of this OAB group, And there we discussed the Foxy recommendations. And according to Foxy recommendations, OAB is nothing but urgency, frequency in the absence of UTI and SUI. Diagnosis is by basically risk factors, history, examination, and investigation. Investigations, again, are simple investigations, not the big urodynamic investigations. Risk factors, old age, obesity, constipation, and vaginal birth. Diaries to be kept that document intake and voiding behavior as well as validated symptom questionnaire. And abdominal, vaginal, and genitourinary examination is very, very important. And a urine analysis, simple urine analysis, routine microscopy, as well as culture may be appropriate. Urodynamics and cystoscopy should not be used in the initial workup of the uncomplicated patient. That's what the Fox recommendation is. Behavioral therapy offered as first line therapy to all of them. This goes without saying. Like diet and exercise is common for all diabetics. After that, you either choose OADs or insulin. Antimuscarinics, anticholinergics drugs, and mirabegron beta-3 agonist are the mainstays of drug treatment. Probably now I would recommend mirabegron as the first choice, having tried the mirabegron on many patients. Refractory cases need surgical interventions. That is mainly botulinum toxin injection and enhancement of the bladder capacity. And final one is urinary diversion. This is the retreat I was talking about. I was a participant there. You can see my colleagues there in the picture. And that was it. Thank you. Thank you so much. Let's meet with the next talk tomorrow.